So
Right.
our next speaker is Dr. Athanasios Kouchostathis. He is currently working in the National Technical University of Athens. Dr. Kouchostathis, the floor is yours.
Thank you. Well, to start off by saying I'm not a doctor. I'm just a graduate student at NTUA, currently working on my diploma, and I'm a high energy physics student in collaboration with the DNA damage lab by Professor Yorakilas. Alongside with the team that you see here, Sisia Damopoulou, Vasilis Rangos, and Professor Koumenis from UPenn, we have conducted a brief review of this new field of flash radiation therapy for you. And okay, this slide changes. So I will briefly discuss what is flash radiation therapy with you, and I will give you a brief history of this brand new field. Then we will go through the first human patients that have already been treated, and we will briefly discuss how we can deliver this new modality of RT. And then I will give you a brief insight on what some of the potential mechanisms for this effect are, and we will finish off with some big questions that still remain partly unanswered. So what actually is flash radiation therapy? It's a new paradigm of radiation therapy, which features ultra-high dose rate radiation of tumors. That is radiation with dose rate. I will denote this as D dot from now on, of 40 grays per second or higher. And what this effect eventually is that while we have this very robust radiation, the radiotoxicity of normal tissue is remarkably reduced, while the radiation maintains its anti-tumor effect. And this way we can also expand the therapeutic window between the tumor and non-tumor control probability, and therefore treat cancer by sparing healthy tissue. So brief history is that this effect was first observed in 1959 by Dewey and Bogue, and when they irradiated Serratia marcinis with X-rays and a dose rate of about 5 to 10 kilograys per second under various conditions. And this led to what is known as the oxygen depletion hypothesis, which is a pretty standard theory, and I will talk to you about this later. Numerous findings supported their ideas about this phenomenon during the 60s and 70s. However, what we call the start of the modern flash is this study that was conducted by Professor Favardon in 2014, in which irradiation of tumor xenografts in mouse model of lung fibrosis took place with a 4.5 MeV electron beam at a dose rate of 60 grays per second, and the results were compared to conventional radiation with a cesium-137 source. Fast forward to 2019, just 5 years after this big, let's say, bang, we have the first human patient, a flash RT, who was treated with electrons at Lausanne University Hospital. And in 2020, the first human clinical trial started at Cincinnati Children's Hospital and the University of Cincinnati Health Proton Therapy Center. The study went on until 2022. And in 2021, phase 1 of the Impulse trial started in Lausanne, in which electron flash was used to treat advanced melanoma. This trial will finish in a few months, and already the FASTO-2, the next clinical trial, has been announced, has received FDA IDE, and has already started. The first human patient was a 75-year-old male who had previously received numerous fractions of radiation. He had T-cell cutaneous lymphoma, that is a skin tumor, and he was irradiated with 5.6 MeV electron beam at the Oriatrini RT6 Linac at Lausanne University Hospital. He received an average dose of 15 grays. However, he did receive all this dose in just 90 microseconds, and more specifically in 10 pulses of 90 milliseconds, and he just received that in pulses of just 1 microsecond. So we have an average dose rate of 166 grays per second but an average dose rate in the pulses of 15 megagrays per second. And this, I think, is the new factor that we have to start taking care of. So you can see in figure 5 that the results were actually quite promising. Yes, there was a skin reaction and it peaked at around 3 weeks, but at 5 months we see no edema at all. The faster one, human trial, had the objective to also test the feasibility of Flash RT during the day-to-day clinical environment, and it focused on the treatment of painful bone metastases. It also wanted to evaluate the adverse effects and the pain response. It took place, as I mentioned, at Cincinnati Children's Hospital and University of Cincinnati Health Proton Beam Therapy Center, and it incorporated a variant probe beam system with open field transmission and proton beam pencil beam scanning with 250 MeV protons and an average dose rate of 51 to 61 grays per second. 10 patients were administered this therapy, and they had 1 to 3 painful metastases in the extremities. However, these patients had no prior radiation therapy to the intended lesions. The results were actually quite promising. We saw that there were no technical issues and delays due to the flash radiation, and the average time of treatment was about 90 minutes per patient. The adverse effects were mostly skin-related, and they were mild and consistent with conventional radiation therapy, and a large percentage reported pain relief, and some percentage reported complete response and no more pain. So this was a very promising study, and it confirmed the feasibility of proton flash RT in the clinical setting, and that it is able to deliver robust results. There's some basic ways to deliver flash and hadron therapy in general. One main way is transmission field irradiation, in which no elements are placed between the beam exit and the patient. Passive scattering method, in which the field is controlled by ridge field filters and collimators and energy modulators, and the pencil beam scanning technique. And another technique has been proposed. It's called the simultaneous dose and dose rate optimization, which employs flash beams in order to irradiate the bounds of the tumor, therefore offering the sparing effect in the surrounding healthy tissue, while the irradiation of the bulk of the tumor takes place with conventional protobeams that form BRAC peaks inside the tumor. The requirements for these systems basically mean that we need higher proton beam affluence and beam current. Our current systems are able to produce these requirements. However, we must be very careful, as we have to ensure that any beam loss is minimal, and that there are very small errors in our system. Also, the need is very high for passive detectors who are not influenced by dose or dose rate, in order to have online real-time dosimetry of the systems. Cyclotron systems have already been adapted for flash radiation therapy, and the reality is that this quasi-continuous cyclotron beam that has a structure of the order of nanoseconds is very suitable for the sub-second dose delivery, which we need to incorporate. While pencil beam scanning can be employed, as it's not dependent on the beam current, most experiments up until now have taken place with the passive double scattering technique. However, that requires very accurate adjustment of the elements between the beam and the patient, and there is also the need for increased monitoring of neutrons, as there is a lot of ongoing activation, and we also need very fast range modulators. Synchrotrons, on the other hand, require different setups. We need to deliver those in what we would call a single spill delivery, which incorporates its own problems in how many protons or hadrons we require to be in that spill. And they also require custom beam shaping elements and specific range modulators, which have to be 3D printed, such as the one showed on figure 12 from GSI. And of course, the placement has to be of all these elements has to be very, very compact in order to limit beam losses. A brand new technology that is being researched, so this might be a hadron therapy symposium, but this is very interesting, is that very high energy electrons have this this behavior of the Bragg curve, which gives us exactly what we want from hadrons. That is the selectivity and the minimal radiation of healthy tissue. As you can see from figure 14, a focused beam can reach the depths that normal electron therapy is not capable of reaching. And they're also indifferent to medium inhomogeneities. So this is a very promising field that's being researched into, and it's also being developed at CERN. Some potential mechanisms for the flash effect, I will present to you. One, the most famous, I think, is the oxygen depletion hypothesis. Basically, the mechanism is as follows. While the irradiation takes place in this very short amount of time, the oxygen in the cells is depleted by all these mechanisms, the radiolysis and the ROS production. And due to this very short amount of time, there isn't enough time for oxygen to further diffuse inside those cells. So the healthy cells appear to be in a state of transient hypoxia, which means that they are more radiation, they're more durable to radiation. This reduces their radiation toxicity very much, while the anti-tumor effect remains unaffected, as the tumors are already in a rather hypoxic environment. Another mechanism that has been observed is that is attributed to the very short irradiation time, which means that the number of lymphocytes that is irradiated is very much reduced compared to conventional radiation therapy. And this means that the compromise of the immune system is minimal. However, there have been studies that have been contradictory to this effect. And of course, further exploration, validation is required. Also, another interesting phenomenon that has been observed is that flash appears to reduce the expression of the TGF-beta cytokines, and that is also a possible explanation of the protective effect of this modality. However, these are just two of the many mechanisms that have been proposed. And of course, I'm not a biologist. I can't really explain many of these things to you, but there are people on the team who are. And the reality is that there are so many potential mechanisms and their combination. So the reality is that this effect is much, much more complicated than we anticipate, and more research is required. Some very big questions, and that's my concluding slide, is that what are actually the underlying mechanisms? And that is something very important, because we have to be able to make some predictions. Only if we understand the mechanisms can we make predictions. And of course, make more targeted tests. And also, what are the exact conditions to induce flash upon tissue irradiation? This is still not 100% clear. There are some indications that there is a dose threshold, dose rate, also what is the exact what are the exact conditions based on fractionation? These are all very important questions, and they are being looked into, and there are many and there are developments, but they have not been 100% answered. And another question is, can the flash effect be induced with combined modality therapy? The answer is yes, from what we've seen, but the studies are very limited and we need more data. And in the end, how can we generalize the results that we get in order to apply them in clinical and preclinical studies? So these are some of the many questions that are yet to be answered in order to have a very clear idea about what is going on and apply this new modality to the clinic. However, I do believe that this is a modality of radiation therapy and of therapy in general that has reached clinical trials in just 5 years after being rediscovered some one way. So things, I'd say, are looking quite well. So these are the references, and I advise you take a look, and thank you for your attention.
Thank you very much for your interesting presentation. Do we have any questions? No, but I would like to ask you something. Is it flash therapy limited only for the for the deep tumors, or can we use it for superficial also? Because you mentioned melanoma. I'm sorry.
What we have seen is that electrons are actually not very high energy electrons. Average energy electrons are better for superficial tumors. That is one of the issue with electrons in general. But with the new technique of very high energy electrons, we can reach deep-seated tumors as well. The first human patient was a melanoma patient, so yes, it can be used, but I'd say that it's more appropriate to use electrons and not hadrons in this case.
Okay, thank you for your answer.